Good day, everyone, and welcome to the ISMP webinar, Prevention of Drug Diversion in the Healthcare Setting. My name is Chris Mahalik. I'm a medication safety specialist at ISMP, and I will serve as your webinar host and speaker. Opioid-related overdoses and deaths remain high. To combat this epidemic, healthcare professionals must do all they can to stop the diversion of opioids and other controlled substances. Drug diversion impacts patient and staff safety. For a patient, it may result in insufficient pain control, substandard care from impaired practitioners, and risk of infections from compromised vials and syringes. For organizations, it can increase hospital costs, result in significant fines for inadequate safeguards. Staff may feel disappointed that they didn't recognize diversion and intervene. Our webinar today is supported by Fresenius Kabi, and we are delighted to have with us today two experts from the field, Ryan Holmeschild and Chris Fortier. Ryan Holmeschild is currently the Director of Pharmacy at Emory Healthcare in Atlanta, Georgia. Ryan has oversight for ambulatory surgical centers, infusion pharmacy services, retail and specialty pharmacies, finance and 340B program, and ambulatory clinical pharmacy services. He has expertise in controlled substance management and oversight within Emory Healthcare and throughout the drug supply chain. Christopher Fortier is the Chief Pharmacy Officer at Massachusetts General Hospital in Boston, Massachusetts. At MGH, he oversees a staff of 400 and all on and off campus inpatient, clinic, and retail pharmacy services. Chris is the chair of the Partners Healthcare Chief Pharmacy Officers Council and works to move pharmacy strategic initiatives forward at the partner system level. Over the next hour, our speaker team will provide guidance to assess your organization's medication use processes for vulnerabilities and to help you identify strategies that may improve the capacity to prevent or detect diversion. Several studies have looked at diversion and the healthcare practitioner. And they all come to the same conclusion pretty much, that about 1 in 10 health professionals struggle with addiction or abusing drugs that are not prescribed for them. Compared to other professionals, studies indicate that healthcare workers have higher rates of substance abuse and suicide, as well as elevated rates of depression and anxiety attributed to job stress, which today is even more ironic. A few weeks ago in rapid fire mode, that COVID pandemic presented itself to us, the likes of which most of us probably could have never imagined would ever happen in our lifetime. We had a lot of emotions. We had fear, uncertainty. Our workflows were quickly changing. There was a lot of pressures at both work and home. As healthcare practitioners, we were called upon to be superheroes, and the pandemic brought lots of illness and death, a lot of times without patients' families present, in some cases caring for and watching our own coworkers succumb to the illness. So even more so now is a time that we need to be more cautious, as the pandemic could serve as a trigger for some practitioners, and the potential for an increase in drug diversion due to job-related stressors could become a reality. Now, it deserves mention that healthcare workers are not at higher risk than the general population. However, the pattern of drug abuse and dependency is unique for healthcare practitioners. Abuse tends to follow drug availability, so you'll see more prescription drugs versus street drugs abused by healthcare practitioners. In addition to the stressors I mentioned, the work pace is unpredictable. Healthcare practitioners work long shifts, rotating shifts, and although there's support from professional organizations and our employers, healthcare professionals have drug knowledge. And a lot of times they believe they can control their drug use. They see the positive effects that drugs have on patients, and because of their knowledge and familiarity, they feel comfortable using the drugs themselves, and they feel that they can do so without becoming addicted. Jordan, can you take me back one slide, please? Thank you. There are many faces of diversion, and I recognize that likely many of the listeners have a story or stories of their own, perhaps about a coworker, a family member, or a friend. This is one story that ISMP had written about a few years ago. Carrie was a 36-year-old hospital nursing assistant. Her mom went to her apartment after she didn't show up for a family function and was shocked to find her daughter dead. And in the apartment was an arsenal of different used syringes, vials, needles, and tourniquets. It appeared that Carrie had collected and stockpiled medications. She had leftover morphine and fentanyl. Some of the products that she had still had patient names and dates on them. She also had stolen urine samples. Investigators believe perhaps that she had done that in case she was asked to provide a sample for drug testing. Carrie had a long history of drug and alcohol dependence, and she had been placed on leave before, but had successful stints in rehabilitation and was able to come back to work. However, she really concealed the breadth and depth of her addiction from her family and her coworkers. And even though the organization had safeguards in place, she still was able to obtain discarded syringes. And they presume that what she did was take them out of biohazard containers and take them home through either a backpack that she carried to work or a small wheeled suitcase. Despite the situation, Carrie actually didn't die from a drug overdose. It appeared what she was injecting at home, sometimes she didn't realize what it was. It might have been unlabeled, and in the case of her death, the day that she died, the drug that she injected was a neuromuscular blocker. The unused syringe had been discarded in a biohazard box after planned intubation in the emergency department where she worked was canceled. The diverter is only one face of diversion. Jordan, could you advance one slide, please? Patients also can be affected, and they can be affected in different ways. They may have incomplete treatment due to dilution of medications, and incorrect treatment due to substituted medications. Bloodborne pathogens might be transmitted to patients through contaminated needles and syringes that were used by the diverter. Errors that may have occurred while their healthcare provider was working impaired may have impacted the patient as well. Organizations are also a face of diversion. They may have feel that they're a failure because they didn't implement safe, effective strategies. They may also be worried about public trust. The staff that actually work with the diverter, some of them may have suspected something was up. They might have even questioned behaviors, and they might feel guilty for not speaking up. They might feel even opposite. They might feel betrayed, that the person betrayed their trust. Others who staff in that setting, they may feel disappointed, and maybe they don't trust their organization. And then the families of both the diverter and the patients are also part of the face of diversion. Patients' families may feel betrayed. They may be worried about their family member. Diverters' families may feel similar to coworkers. They might have suspected, maybe they feel they didn't question enough. Some may be shocked because they didn't see it coming at all. Next slide, please. In the case of diversion, no news is not good news. Only a fraction of those who are diverting are actually ever caught, and even despite the signals when they're present, such as abnormal behaviors, physical appearance, and poor job performance, or some of the ones that are typical, they might not be recognized. There was a group that looked at records from the CDC and the medical literature related to infection outbreaks, which is another outcome of diversion. They looked at these outbreaks between the years of 2000 and 2013. And over a 10-year period that started in 2004, there were 6 outbreaks. They all occurred in the hospital setting. 3 involved technicians, 3 involved nurses, one of which was a CRNA. The mechanism by which the infections were spread was tampering with injectable controlled substances. 2 of the outbreaks involved tampering with opioids administered through patient-controlled analgesia pumps, and they resulted in gram-negative bacteremia in 34 patients. The remaining 4 outbreaks involved tampering with syringes or vials that contained fentanyl. Hepatitis C virus was transmitted to 84 patients. In each of these outbreaks, the implicated healthcare professional was infected with hepatitis C. And nearly 30,000 patients were potentially exposed to bloodborne pathogens, and they were targeted for notification, advising testing. Now, since the end of that review, since 2013, there have been 4 additional US outbreaks associated with drug diversion reported to CDC that represent an additional 60 cases. So illicit drug use by healthcare workers remains an important mechanism for the development of bloodstream infections in hospitalized patients. And these outbreaks really highlight gaps in the prevention, detection, and response to drug diversion in our healthcare facilities. So you can see why opioid stewardship really does matter. And by stewardship, I mean a coordinated effort designed to improve, monitor, and evaluate use of opioids. Next slide, please. The strategies used to eliminate risk for drug diversion and support medication safety can be tested against the same hierarchy that we use when evaluating medication error strategies, which is what you see on the slide here. Essentially, we want to make it easy to do the right thing and hard to do the wrong thing. So strategies towards the top of the hierarchy are stronger than those that are lower on the list. For example, a strong diversion prevention strategy would be to favor automation of drug storage and accountability compared to using a manual method to dispense and track controlled substances. Another example would be to provide access to a single tamper-evident unit of an opioid dose in the exact ordered dose required for patient care as a higher level strategy compared to providing a dose that would require manipulation, like removal of an amount of excess of what's ordered or needed for patient care. Next slide, please. Diversion is a medication safety risk. So let's look at some ISMP-related recommended practices that support safety and eliminate the risk of diversion. From a structure standpoint, when a risk is identified, and that risk could be tampering, it could be confirmed loss, it could be a discrepancy between what's actually present and what's expected to be present. What we look for is a rapid multidisciplinary response process. And it should also include addressing patient care. For example, there may be a situation where investigation of the risk identifies an error where a patient received the wrong dose of an opioid. So you want to have a quick response and a multidisciplinary response so that we can intervene and perform patient assessment if that's the case. From a procurement standpoint, we recommend reviewing the package sizes that you have ordered into your facility. And we want to drive purchasing towards ready-to-use products. But more ideally, the best practice would be to supply ready-to-administer products. And what I mean by that is the exact dose required to avoid any manipulation. If you're unable to procure a ready-to-administer dose and you need to purchase a vial or ampule of an injectable opioid medication, ISMP recommends using single versus multiple dose packages. But even with single dose vials or single dose ampules, to the greatest degree possible, we want to avoid the need for practitioners to waste excess drug. Another method to support safe practices is to avoid practitioners' dilution of ready-to-use or ready-to-administer products. In fact, ISMP doesn't recommend that IV push medications be diluted unless it's recommended by the manufacturer or it's supported by evidence in a peer-reviewed journal, or it's in accordance with an approved publicized institutional guideline. When compounding opioids, if you can, avoid it. But if it is or becomes necessary Take a look at your compounding formulas to avoid the use of vial sizes that would result in a partial vial being left at the end of the compounding process. When you're designing those compounding formulas, incorporate the overfill amount in vials and ampules. Have your staff expect and document that amount. And if you're compounding, utilize tamper-evident closures. From a technology standpoint, ISMP supports automated dispensing, documentation, and then monitoring use of metrics to ensure that staff are in compliance with technology use. Next slide, please. Before I hand over the program to Ryan, I just want to highlight 3 ISMP references that all have key best practices to support safety and eliminate risk for diversion. Our guidelines for the safe use of automated dispensing cabinets, ISMP safe practice guidelines for adult IV push medications, and ISMP's medication safety self-assessment for high alert medications. And with that, I will hand over the virtual microphone to Ryan.
Thank you, Christina. Thanks everyone for joining us today. My goal in my section is to talk about how to create a culture of controlled substance oversight and hospital-wide engagement, knowing that we can never have too much oversight or our teams be too engaged when it comes to controlled substances. And so we are always on a journey of constant improvement. And so I want to talk you through some of the steps that we've seen here along our journey. If you could advance to the next slide, please. So our catalyst for change, about 10 years ago, there was some diversion detected here at Emory and actually made it into the local paper. Most of the pharmacy leadership has changed since then. However, this was a catalyst for our hospital to get more engaged in controlled substance management and really revitalize the culture in our approach. Next slide, please. So as we saw originally, and as many of you may have seen, there was a culture of trust, which is not a bad thing. However, sometimes if you're not able to verify that people are doing as they should, you get a false sense of trust. Here's a few quotes that people had said about the times before our culture revitalization. Trust us, it's okay. It is a lot of waste from the vial, but it's the cheapest vial available. I purchased this order, but I recognize that this inventory technician called out. I'll just go ahead and receive it too to be a team player. Or I have a discrepancy in the machine. I notified pharmacy, but I got to go to lunch. I'll deal with it when I come back. And as we know, a lot of this can be done with good intentions. However, it leaves opportunity for diversion when there's not close, tight oversight. Next slide, please. So what we want to do is create a trust but verify culture. We know that originally patient care will often be cited as main reasons why people need workarounds or they don't need medication stored in automated technology or robust reconciliation processes. We originally saw that there were less restrictions on our buyer access in case they needed to be a team player. Intentions were good, however, those segregation of duties, it leaves gaps in our controlled substance program. We saw that procedural areas historically had lacked automation. Physicians, nurses, teams wanted just-in-time medication reconciliation. They wanted to be able to access that drug in case a patient wasn't doing very well on the table. However, that again leads to more gaps in the process. We had checks and balances within our controlled substance program. However, accountability did not always back them out. If we sent a report to one of our team members, a nursing supervisor, a lot of times they try to review, but there weren't robust processes where they got that back to us in a timely manner, or they themselves had the time to do a deep dive into some of their nursing colleagues. And lastly, one of the biggest takeaways to find everyone, just because you don't have diversion problems detected within your system does not mean that there's not diversion going on. Sometimes a lack of reporting or a lack of catching individuals diverting, there's a bigger problem brewing in the background. Next slide, please. So I want to talk to you about the culture shift. We want to have a comprehensive overhaul of controlled substance programmatic oversight and involvement. And this even means hiring a controlled substance program manager at the system level who's highly in tune, highly competent in how we can look at processes across all hospitals. But first at our hospital, we first had to engage hospital leadership and C-suite. We had to make sure that controlled substance oversight and involvement was not just a pharmacy problem, but it was a health system problem that everyone had to be a stakeholder in. We also recognized that we needed to perform a gap analysis. We needed to utilize tools from leading best practice organizations like ISMP to make sure we're evaluating every section of controlled substance management, from the different phases of care, inpatient, ambulatory, surgical center, retail, infusion, and also from supply chain, medication administration, storage, use, and waste. We really had to make sure we were comprehensive in our approach to have the best program, or to seek to strive to have the best program possible. After that, we had to do a risk stratification. As you can imagine, there's gaps that have been identified. And so how do we develop an action plan to reduce those gaps? And how do we work with our system and entity level leadership outside of pharmacy and within pharmacy to make sure that we prioritize each strategy appropriately? And then lastly, you have to identify individuals on the team to lead the initiative. What additional or repurposed positions are needed? Maybe we have people that can do the work, however, their time's not being utilized as successful as it could be. How do we rearrange their work to make sure they're more effective? These are the types of conversations that we had to have as we started to go through this culture shift. Next slide, please. So one of the first strategies that we focus on is the art of perpetual inventory. Over these next few slides, I'm going to go through a few higher level strategies that we feel like are important on your journey to a robust controlled substance program. The first is understand the life cycle of controlled substances. Each automated dispensing cabinet is going to be focused on different units within the hospital, within the ambulatory surgical infusion center, whatever phase of care. It's important that those PAR levels are designed for that specific patient population. And then when those PAR levels go down, that automated dispensing cabinet can push out PAR levels to the buyer so that they can understand what needs to be purchased. The more we can reduce manual intervention and rely on robust systems in place, the better our processes will be. So this means that we need to utilize controlled substance management integrated within an automated dispensing cabinet system. We should be able to account for every dosage form, which is proposed in the purchase, when it's bought, when it's received, placed in the centralized vault, out to the floor, and finally administered, wasted, or returned. We should be able to track that unit of use across all different areas within the health system. We know that we need a controlled substance order that's generated based on unit utilization and those established PAR levels, and that if there's any adjustment to those PAR levels, that we can document it, we can track it, and we can make sure that there's oversight into those adjustments. We also want to make sure that medication can be requested and tracked through software that prevents medication from disappearing from the safe to the floor. When it leaves that safe and automated dispensing cabinet, the floor should be expecting the exact count that was pulled. That way you can account for any medication missing in the interim. And that's a consistent theme that you want to see throughout your continuum of care. Next slide, please. After perpetual inventory, one area that really parlays really well is the traceability of controlled substance management. Something I hinted at in the previous slide. You want to make sure that almost all your transactions are occurring through an automated dispensing cabinet or through the software. And even those PRN and patient-specific doses that are sometimes more difficult to make sure they're loaded within the automated dispensing cabinet. You want to make sure you have direct hand-to-hand delivery of medications that cannot be loaded into the dispensing cabinet with signature confirmation from two separate individuals, and you actually have oversight into that paper form with a lot number, so you can expect it to be returned after that medication's been handed off. You want to make sure that if there's any issues, any comments, anything that needs to be documented related to a controlled substance, that can happen within the automated dispensing cabinet software. So you have it documented, you can pull it at any time, and there's a track record for it. When we focus on controlled substance reconciliation, we want to make sure that not just the movement of the medication is documented within the system, also that you have a mechanism to waste medications within the electronic system. You want to make sure that it can track who is wasting, the patient, the medication, the dosage form, and again, a big theme is we want to reduce the amount of waste that's ever required. You also want to complete a controlled substance administration record. Make sure it's linked to electronic medical record for documentation. If there is a drip, you need to know what that bolus rate is, what that basal rate's going to be, and that way you'll see a perpetual use of medication that should match what that closed loop pump technology shows. That way, when pharmacy receives any medication left, it can be reconciled with what's in the EMR. It creates a more robust reconciliation process and allows for increased oversight. And lastly, in terms of traceability, we talked about monitoring the medication from purchasing in the previous slide to either administration, waste, which we just spoke about, or returns. You want to make sure there's a way to return medications. You can link the healthcare employees that are returning the medication, the patient, and again, that allows for complete robust oversight. And you can see the perpetual use of that medication throughout the entire supply chain. With that being said, I'd like to transition you to our next slide. This one focusing more on segregation of duties. We've talked about perpetual inventory. We've talked about traceability. And the other thing that's really important to a robust process is to have segregation of duties. You want to reduce any opportunity of diversion within the department and outside the department, any opportunity people have to conceal diversion. We talk about automation a lot, but I'll say it helps propose the automated PARs. And so with that, when you build in controlled substances and you have them set for each of the specific areas, when they go below the PAR, the controlled substance automated dispensing cabinet will receive an alert of how much needs to be restocked. That alert can also be pushed out to your purchasing software, to your distributor, to make sure that you're only ordering what's needed and what's been validated based on those units. You can have a pharmacy buyer then that reviews the proposed order, and if you are a disproportionate share hospital, can split with the billing vendor or can then push on that proposed order within the distributor for review. You can have another independent pharmacy leader review that order and then determine, is this appropriate? Does it match what the automating cabinet recommended? And if so, they can submit that order each day, and it allows for pharmacy leader oversight to the process. A pharmacist then, when that medication order comes in, receives the order against what was submitted, to ensure that the medication that was purchased and asked for has been received, and any variances can be followed up right away. And then lastly, once that order is then checked in, you put it back into the automation dispensing cabinet, and that cabinet will say, well, this is what I recommended for purchase, and this is what came in. And then the automation can then reconcile to as another check to make sure that no medication disappeared in that entire process. It's pretty robust, but we found by segregating those duties and not having everyone perform the same ones reduces the chance for concealment and reduces the chance for diversion. Next slide, please. So with that, after having your supply chain, your traceability, and having really robust segregation of duties, you need to have a proactive, not reactive process to review your controlled substances in an ongoing monitoring process. The most important opportunities is to select a third-party software or a software to establish an ongoing review of the Omnicell dispensing cabinet data. You also want to make sure it's hooked into your wholesaler data, so you know what's being purchased, what's being checked in, so that there's reconciliation that can occur throughout the entire process. It also enables you to have really strong auditing platforms. Recently, not recently, but now the standard of practice is to make sure that you have a third party or auditing software that utilizes artificial intelligence and has learning capabilities. In the past, we would audit and send the reports on and review the reports, but now you want software that has learning capabilities, can learn from the organization, from the unique unit of the MICU versus the SICU, and be able to reconcile that data and be it front-facing to your controlled substance vendor. That makes it more effective, timely, and informed decisions around that data. And you want one that's going to get smarter as time goes on. So it keeps learning, keeps allocating that data, so it makes you more efficient and allows you to review more cases. Also, you want to make sure if you're running reports that you do it with a relevant frequency and that you create robust follow-up, not just from pharmacy, but from external stakeholders. You want to be intentional with your data, Make sure that people are providing you real-time review and feedback and not waiting a few weeks to get back to you on something that needs to be right away. And lastly, establish benchmarks for all areas of the hospital. Not all areas are the same. A surgical center is different than an inpatient unit, than an infusion center, than a retail pharmacy. But at the same time, within that inpatient hospital, the surgical intensive unit is going to be much different than the medical intensive care unit. You need to pick appropriate and relevant benchmarking areas and continually reassess as changes in practice occur, like COVID-19, practices in sedation. It's got to be part of your ongoing review. Next slide, please. So lastly, the safe handling of controlled substances. We want to make sure that we're utilizing closed loop pump technology regarding all transactions. Make sure you're utilizing the smallest dosage form possible to reduce waste or medication error. You also want to be consistent, utilize that same NDC so that you can accumulate on it, but also that your nursing and pharmacy colleagues all treat it the same way. Have the same volume, the same concentration, therefore they can build in safe practices and be alerted if something looks wrong. Avoid using bulk dosage forms and setting up all doses and patient specific. And I know this can be difficult, especially for parenteral oral liquids. A lot of times we want the nurse to pour out the dose because it's a lot of work to load that patient specific volume every single day. But it's important for traceability and to reduce the chance of having excess waste. You want to make sure that you have barcode scanning on all products. If barcodes aren't there, how do you create barcodes that'll be efficient and effective? As well as utilizing RFID technology so that you can quickly identify if something's missing. You can have very specific tracking within your facility. And I would also recommend that you utilize pre-filled, ready-to-administer syringes. This is important because it reduces the amount of manipulation from a sterile compounding perspective, from a waste perspective, but it also reduces the chance of someone diverting when they have to manually draw up or manually manipulate a medication after it's been dispensed. Next slide, please. A few things that make this presentation even more relevant is COVID-19. And here are some considerations building off the past few slides that I want to share with you all. Because controlled substance management changes a little bit because you have to become more dynamic during a pandemic. Individuals are now wearing face masks, so having cameras is great, but if they're wearing a shield where light's reflecting off in a face mask, it's really hard to identify who's going into a specific area. How are they procuring controlled substances? Make sure you utilize individual usernames and biometric IDs. We have an increased number of traveler nurses and health professionals. More people are helping out as we have higher acuity patients or we have individuals getting sick from our own healthcare team. How do we make sure we have robust processes to establish temporary privileges, but there's someone dedicated to that work, can get a fast turnaround time, and also can continue to monitor if someone's no longer on the unit or no longer practicing or traveling, their access can be turned off right away. And the other important piece is controlled substances may be in non-traditional areas. Many of you know we're struggling with shortages. We also are caring for patients and setting up temporary ICUs in areas we most historically have not. We may not always have the capital funds in this trying time to fund automated dispensing cabinets. So it's important, extra important, that we utilize medications with tamper-resistant packaging or shrink wrap. That way we can easily identify if something's been manipulated. We can still have safe processes, but it's an extra layer of how the medication manufacturer can set us up for success here in the hospital and health system. So we recommended purchasing medications that deter diversion, also reduce waste, right? The most appropriate dose. Don't leave waste for those nursing colleagues or physician colleagues. And do this especially in areas with less. I know in our Atlanta community, I've had some community ambulatory surgical centers reach out to me since they don't have the automation we have, and they've been working on how do we create a progressive oversight for an area that doesn't have automation, and it's utilizing these types of tools. Next slide, please. So warning signs, individuals who frequently volunteer to witness excessive or late administrations, people that are carrying around medications in their pockets, these are all things that you need to be aware of during COVID and outside of COVID. And unfortunately, this can impact any major life changes, frequent disappearances from the floor, or people that have periods of high or low productivity. Unfortunately, diversion does not discriminate, and you never know who could be within your health system. But these are some warning signs that have been identified in literature that you need to be aware of. Next slide, please. And lastly, have an internal control escalation pathway. Be able to identify unusual behavior if there's tampered controlled substances, like we showed in the previous slide, if there's any late administrations, people that are administering medications consistently for other practitioners. Alert that diversion charge nurse, have someone that's able to look through that right away, can partner with the pharmacy director or CNO if they feel like diversion is occurring, and then you immediately can have that pharmacy administrator on call and get the right people to the table so you can address it in real time. Next slide, please. So our end goal, we want to have outcomes we are measuring for success. We need to have those executive sponsors receive a report out on controlled substance management and be engaged in the process. Have tight control within pharmacy operations and have several different segregations of duties to reduce the chance of concealment inside the organization and outside. We need to make sure that technology is leveraged for oversight and security, that we're supplying medications in the smallest unit of use, setting up our practitioners on the floor for success so that they have less to document or have waste. We want to make sure that pharmacy has a reputation for following up. People are like, wow, pharmacy is going to be looking at that. Let me pharmacy before I do that. We want everyone to know that pharmacy is engaged in this process. And lastly, have data, especially with artificial intelligence, of real-time retrievable data that you can utilize and analyze and make smart decisions as you move forward. So I'll end with this last slide. The next slide, please. I'll end with the last slide. And what it really does is show the difference between before and after. Now we have people saying, I feel like pharmacy's watching. My pharmacy makes my job easier by providing me some type of pre-filled syringe with the examples. Our procedures are clear. This is a unique situation, but let me reach out to pharmacy before I just leave this description machine. And I think haven't arrived yet, but we're on our journey there, and that's what's exciting to me. So without further ado, I'm going to turn the presentation over to my colleague, Chris Fortier, and he's going to speak to you about his perspectives.
Great, thanks, Ryan. Good morning and good afternoon to all of you, and hope everybody is doing well and staying safe. Next slide, please. So many of you may have heard me speak on this topic in the past. My story around drug diversion really starts when I started in my position here at Mass General, and at that time we were under DEA investigation for drug diversion. And really sort of tried to set sort of a call to action around what institutions should be doing around this dilemma. And hopefully today I can give you a pretty good summarized version of the different areas that you can be considering around drug diversion for your institution, both within your department and across the hospital. What I'd like to go through today is just really first start talking about the critical requirements and focusing within those critical requirements a little bit more on surveillance systems and really what you should be thinking about moving forward, as well as sort of your own pharmacy, I'll call it controls. What are the things in your shop that you can best take care of? And some of that has been described a little bit already today, but just those two things I really want to highlight. Then I'll talk quickly about some COVID considerations, and then finally end with sort of the challenges that we still sort of face in this and how can we best overcome those issues. You can see here on my slide, I'm at Mass General Hospital in Boston, and as you can tell here, we dispense a lot of controlled substances on an annual basis and have a large number of employees that have an impact, whether it be writing prescriptions for controlled substances, distributing, storing, or administering medications across the system. And of course, we have to have a solution in place to make sure we're having surveillance around all of that to ultimately, as you know, to protect our patients and ensuring that they're getting proper medications. We do have a large number of automation across the institution as well. And I'll go through some more specifics about what we have here in our location as I go through the presentation. Next slide, please. So I've sort of broken this out as I have in the past, about 10 different critical criteria that I think all institutions need to consider. And this is really sort of from our personal experience through all of this. And we continue to refine this process. There's more that we always add, or that I always add as I give more of these presentations. I'd first say, really, we have little direction from the DEA about what to do and how to do it. There is some stipulations, but it's very general, and it becomes very difficult for how do you do it in the best way and hopefully the most efficient way. I would say the second component is that really things need to be multidimensional. This is not one silver bullet that's going to solve all your issues, and therefore the reason for sort of my list of 10, and I'll go through this 5 in a moment. And then one thing I'll just say to think about today as I go through my portion of the slides is think about where do you have strengths in these areas and where do you have some opportunities, and sort of conducting a little bit of a gap analysis, and how do you make that part of your strategic plan with whomever on your team in terms of moving forward. I think the number one thing, and I hear most organizations have really probably the first thing that they did is they try to start this journey was putting together a drug diversion task force, and that being multidisciplinary, a group that's meeting on a regular basis. They're reviewing either incidents that happened or reviewing data, having some sort of formal charter and potentially even a strategic plan of what are the different areas that your institution identifies as gaps that team can help address. And the experts on that team, whether it be pharmacy, nursing, police and security, can help to sort of close those gaps, either based upon incidents that have happened or just things that you're a little bit concerned about that you want to get a little bit more on top of. You know, we've talked a lot about creating the culture in this presentation today, and I think one of the biggest components of that is really staff education and competency. If you are not doing some sort of annual staff education, you should really consider that. Things around sort of signs and symptoms, policies related to controlled substances, how do you report staff? Are there specific area training components that need to be within that? And also maybe even the component of competency in that. So not just sort of didactic education, but what sort of competency that you can ensure of your staff. Therefore, we do have competencies in staff education for pharmacy, nursing, and anesthesia in our institution. Number 3, I'll come back to in a second, but really is around surveillance programs, electronic surveillance programs. As you know, this can be a lot of work. It's in many cases, very manual, and really want people to be thinking a little bit more into the future, into the next steps around this specific item. Number 4, investigation. So what is your process to investigate when you've identified an issue? Do you have a standardized process? Do you have a team that gets together? Again, probably much like a drug diversion task force in terms of the people that are involved. You know, if it's a nurse, nursing leadership, pharmacy, police and security, employee health, occupational health, what about HR? What about employee assistance team members on those groups? And so how are you going about it? How far are you going back to look at data in terms of your investigation and finding, hopefully, the information you need to determine if this has been a diversion or is it something else? Is it sort of nursing or provider practice? I would tell you our standard is if we've identified an issue within 24 hours, our response team is getting together. Again, it's that multidisciplinary group. And it may take a couple meetings to sort of determine what we need to do to get the data and discussion around that. But I will say we want to obviously ensure patient safety. And so putting that clinician or provider on investigatory leave as immediately as possible is what we do, and then investigate a little bit further and either bring that person back or if there is a diversion issue, addressing that appropriately with that employee. And I'll talk about that a little bit later in the HR section. Number 5 here is reporting. So this is probably one of the most difficult pieces in terms of lack of clarity from the DEA. The DEA says you need to report a significant loss. But as you all know, you may define significant differently than I find significant. And you may have state laws that require different reporting than the federal laws. And I think just really the key is having a standard approach and sticking to that standard approach, whether that be in some sort of guideline or policy that you have in your organization. At our institution, we use sort of the greater than or less than 5 rule. So if we have a loss of greater than 5 syringes, vials of something, we will report that as a DEA 106. Our state requires us to report just any loss. So even if it's one, it's pretty clear that we need to report that. But really find that standard process and how you're reporting out, how you're documenting those reports when you're sending them out. And one sort of caveat that I always like to share is sometimes difficult. You kind of don't know what's going on and you're unsure if you should report. I always believe send as much information as you know as possible. You can always provide an addendum to that report once you get more information, but better to submit it within the 24 hours in terms of the DEA or whatever your state requires in terms of that time frame. Next slide, please. Okay. So one of the areas I want to just really kind of highlight here is, electronic surveillance systems. I think we've had, systems for a while that are pretty sort of limited in terms of their functionality. They go based upon standard diversions or standard deviations, and determine, well, this person is using a little bit more controlled substances than their peers. But it really doesn't give us, and all the data points that could have an impact, it doesn't really give us that information. I think over the last about year or so, we've seen new products come to market. And I'm not here touting one or the other, but really just pushing people to look at other systems that are out there that could provide more sort of intelligent review of the information and sort of providing more data around potential episodes of drug diversion, with the hope, of course, of catching things earlier in the process than maybe later. So I've sort of listed here a couple things that many of you would probably say, yeah, my system doesn't provide this today, or hey, for me to find this information really takes a lot of time. And so again, how do you use this to your advantage? I will say, this comes with a little bit of concern in terms of you're going to have a lot more data. You're going to have a lot more data points. And so how are you going to work with your nursing colleagues, your anesthesia colleagues, the pharmacy team to say, all right, we have some more information now. I'll give you an example. So delay in documenting of waste, right? Are you going to put parameters around that? What happens if a nurse goes outside of those parameters? And is there some sort of repercussion to that? It may not necessarily be diversion, but what are you going to do? So anyway, I really want to encourage people and make a point of this, as this is something you should be thinking about, because the process is extremely manual and you're looking for the needle in the haystack. You need to be able to have a system that promotes the exceptions to then dive deeper into those and investigate versus just kind of, like I said, looking for that needle. In terms of the other 5 areas that I would really encourage that I think are critical, number 6 is auditing. So what is your process to audit your inventory? FDA requires biannual inventories. For a big place like ours, that's a lot of data to go through. And if there's a problem, I'm going to have to go through 2 years worth of information. We've done things where we've sort of broken out things a little bit more. Probably we're doing really an annual inventory once a year, but every 6 months we also do, we look at sort of the drugs that are of most concern, and we do a sort of an accountability audit related to those items as well. So what is your auditing process? Are you using external auditors? Are you doing it yourself? How are you reporting that information? Again, the DEA doesn't provide data, it just says do a biannual inventory, but what does that ultimately mean? So be thinking about how the best way to go about auditing your cabinets, auditing your narcotic vaults, and doing that on a little bit more routine basis to lessen your time that you're going back to look. And if there is a problem, you can find it a little bit quicker than, ultimately waiting 2 years. I think most of us now are using a variety of technology in terms of automated dispensing cabinets, anesthesia workstations. So I won't go into much detail here. I think the big piece around technology is around just the functionality of it and where there may be gaps in the system of what maybe you've a functionality component that you have turned on or maybe have turned off, and really doing sort of an assessment, working with your vendors to say, hey, is my system as tight of a process as it needs to be, or do I don't have certain functionality turned on that I could be using to create better better surveillance, better tight storage of our products or your products in that process. So I think really focusing on functionality and potentially some limitations of that is important. I'll come back to pharmacy controls in a second and move on to human resources. So as I said earlier, I think, human resources and engaging the human resources department in your organization, I think is very important of this. In the end, we want to support employees as much as possible. As we know that this is a disease, we want to help rehabilitate our staff as best as we can. Now, the way that we sort of play the game is ultimately, if we've identified you've been diverting and you're willing to cooperate with us, we want to get you help. And we need to work with HR to do that, and potentially even bring you back into the organization. And what ultimately is that going to look like in terms of specific criteria that will allow you to come back. But how are you working with the employee to potentially rehabilitate them? If they don't cooperate, then unfortunately we sort of cut our ties with that employee and move on. The other thing I think that's important as well is, how are you documenting situations that may arise? Maybe it's not an issue of diversion. Maybe it's a bigger issue of you lost a large amount of drug. You're not really sure. You don't think it's diversion. Or there's an employee that's just not documenting things appropriately in the system, or their workflow of that documentation process is not right. How are you documenting that process? And you need to really work with HR to be standard, because what will happen is, if the DEA ever comes in and says, and you say, oh yeah, I've talked to that person. Well, again, as you know, just like anything, if you don't have it documented, it didn't necessarily happen. So I think be thinking about that process and how you put that in place for nursing, anesthesia, pharmacy, whatever it may be. And then finally, multidisciplinary collaboration. Again, this was spoken about a little bit earlier in the session today. Is, what about that multidisciplinary collaboration? It's really, really critical to be able to be successful and to have the program that you need. Lastly, I'll just say about the top 10 pharmacy controls. I very much believe you need to have your house in order yourself. Many of these other things are sort of somewhat could be beyond your control, but make sure you have your process figured out in your institution and you have the right checks and balances. Again, the previous speaker talked about this, but or actually both previous speakers talked about this, but think about the products that you buy. Yes, this may be difficult because of drug shortages and what you can get your hands on, but how are you buying ready to use, tamper evident? How can you reduce the error around that use of that product? Again, I won't get into this because it's been discussed, but again, another major point that I want to make for today. So I'm getting close to time here. I want to just quickly go through, lastly, things to be considered around COVID and controlled substances. At our organization, we had almost 300 COVID patients in the hospital. 200 of those at our peak were in the ICU. And as you can imagine, we were using a lot of controlled substances and having to purchase a lot more controlled substances than we normally have because of these ICU units. And as you can see here, there's a couple things I want you to consider as we sort of shift back into whatever the new normal may be. Think about redeployed nurses and physicians, right? We were seeing more discrepancies. We were seeing more overrides. We had traveling nurses in the organization to help support the increase in ICU beds. And so how are you looking at that, and how are you ensuring that you're not having any diversion with sort of this influx? Obviously, higher volume of controlled substances, both purchases and utilization, limited access into the patient room. So what is the wasting and the witnessing process? How has that changed, and is it standardized across the organization, or is there some opportunity there? We've seen a little bit of a lax of federal and state requirements, which is a good thing to allow certain people to prepare more controlled substances. But again, with that, I think we need to keep our heightened awareness around that and make sure that we have proper oversight. And many of you may have created field hospitals with your town, with your city, either related to your hospital or you are a part of that. And so what are you doing around controlled substances in those locations as well to ensure, again, proper compliance and proper surveillance? One thing I'll say, and just sort of moving forward, we really don't know what the mental health impact to healthcare providers around this whole pandemic is going to be. Will we see greater amounts of drug abuse in this situation? I think it's kind of too soon to tell. but obviously there's the potential for that. And so keeping our heightened awareness around that. Obviously, not shifting your resources because you're focused on COVID is you need to continue to maintain the resources around your surveillance and evaluating trending reports to make sure you're not missing anything. I talked a little bit earlier about accountability audits. We bought a big amount of controlled substances, and one of the things I was talking with my colleague about recently was, should we kind of do an accountability audit over the next couple of weeks to make sure that what we purchase continues to remain, obviously being utilized appropriately, and make sure we have that perpetual inventory of those products, because again, it was a little bit of an anomaly of what we purchased and utilized. Password and access cleanup, I think, will be important moving forward. And then just what will be the new processes that could have an impact on controlled substances that are related to COVID. As you're reopening your operating rooms to more elective procedures, how is that going to impact things? So be thinking a little bit ahead on how you may have to pivot a little bit in those cases. And then finally, I'll just talk really about challenges or just goals and kind of next steps. As I said earlier, the goal here is to have a comprehensive program. It's not one thing that you need to have in place. And so hopefully today you were able to kind of think about your gaps and where you need to kind of maybe focus some more efforts. The process is manual. We have limited resources. And so what other strategies can we use to reduce our risk, to improve our surveillance program? And I think I pointed out both of those. I talked about little direction from the DEA. And so how best can we all share our examples of how we're handling things like how we're doing a biannual inventory or how we're reporting things. I think pharmacy is great at sharing that information, and we should continue to do that. And then finally, multidisciplinary collaboration. We sort of got forced into this through our DEA investigation, but how are you engaging the other disciplines to be right there with you to sort of ultimately create this culture? So I will turn it back to Chris, and I think we'll take some question and answers.
Yeah, thanks, Chris. Thanks, Chris and Ryan. Our first question goes to Ryan. Ryan, what system and where are you utilizing RFID in the diversion prevention process?
So I would say RFID is something that we're evaluating in totality to see where it can be utilized. A lot of people are familiar with RFID technology within crash carts. We also use RFID within the health system to track pumps and things of that nature. I think where we're looking at is how do we expand RFID past those traditional locations? And is there any utilization to have RFID outside of just crash carts, but to have it on some products in the pharmacy? And so I think that's the evaluation we're looking at, is how do we take RFID to the next level? But in current state, we're not there yet.
Thanks. Chris, at Mass General, is the staff education that you're providing the same program for pharmacy, nursing, and the medical staff, or are there 3 different programs?
There are 3 different programs. They all sort of have, some similarities around, looking for the signs and symptoms related to potential drug abuse, drug diversion. But then it gets a little bit more specific in terms of sort of the workflow and processes and the policies around each of those different entities. So I would say probably it's about 30%. Everybody has the same content, and the rest is very much specific to those different providers.
Here's a question for either of you. Are there any good practices for flight teams and ambulances that you can share?
Ryan, go ahead if you have an answer to that.
I haven't thought of that in particular. It's definitely a risk point within the process. Nothing comes to mind off the top of my head, though.
So from MGH's perspective, we don't necessarily provide controlled substances to those different entities. I will say, though, when we do transition a patient to potentially either a flight or an ambulance, and they are on a controlled substance, let's say they're on an IV of some sort, there is some paperwork that is completed to sort of hand off that product from our DEA to their DEA that we keep on file. So that may be something to consider sort of as it sort of leaves your chain of custody, that you have documentation of that.
Okay, thank you both. Thank you both for your presentations today. We are at the top of the hour. I want to thank Fresenius Kabi for their support of the webinar today. I'd also like to thank all of our attendees for listening, and I hope you all have a wonderful week. Thank you and have a great day.